Question 1. The central argument for performing a thorough assessment of venous valves during a duplex ultrasound exam lies in the sonographer's ability to distinguish between competent and incompetent valves. During a lower extremity venous ultrasound, Ramirez exhibits retrograde flow in the great saphenous vein lasting more than 2 seconds following distal augmentation. However, the vein is not visibly dilated, and the patient reports no heaviness or discoloration. What should the sonographer conclude from these findings? A. The valve is competent as there is no physical symptom or vein dilation. B. The presence of reflux 2 seconds indicates valvular incompetence regardless of symptoms. C. The findings are inconclusive without observing the patient during standing. D. Valvular competence cannot be determined without measuring vein diameter. Answer. Correct answer. B. Explanation. Reflux greater than 0.5 seconds in superficial veins, particularly after augmentation, is indicative of valvular incompetence regardless of symptomatology. Ref. Society for Vascular Ultrasound SVU guidelines, while physical symptoms and vein diameter help classify the severity. G. Seat classification. Valve function is determined primarily through Doppler reflux timing. Therefore, even absence of clinical signs, reflux 2 seconds confirms an incompetent valve. Option A is incorrect because absence of symptoms doesn't rule out dysfunction. C adds detail, but standing isn't required to establish incompetence here. D is incorrect as diameter alone doesn't define function. Question 2. From a practical standpoint, understanding when to use continuous WUV EW versus pulsed WUV PW Doppler is critical in clinical ultrasound. Which of the following best illustrates an appropriate application of a Doppler in venous ultrasound? A. Identifying venous reflux in a perforating vein. B. Measuring peak systolic velocity at a specific site in the femoral vein. C. Assessing long segments of veins when aliasing is suspected. D. Locating compressible calf veins. Answer. Correct answer. C. Explanation. A Doppler which transmits and receives signals continuously is ideal for detecting high velocity or extensive flow patterns without range specificity. Beneficial when aliasing a EW Doppler, offering range resolution is preferred for site-specific velocity measurements. Option A is incorrect as perforators require localized sampling. Best assessed with EW Doppler. B. Also requires EWD is unrelated to Doppler principles and pertains to B-mode imaging. Question 3. To illustrate this point, MS. Cortez, a 52-year-old patient with a history of recent varicose vein treatment, presents with a palpable tender cord along the medial thigh. Duplex ultrasound reveals a non-compressible great saphenous vein segment with echogenic thrombus but no extension into the common femoral vein. What is the most appropriate next step for the sonographer? A. Conclude the exam and document superficial thrombosis only. B. Perform a complete bilateral venous reflux study. C. Extend imaging proximally to confirm there's no propagation into the deep system. D. Immediately refer the patient for emergent intervention. Answer. Correct answer. C. Explanation. In cases of superficial thrombophlebitis, especially when near the junction with deep veins, e.g. SFJ, it is essential to ensure thrombus has not extended into the deep venous system due to risk of embolization. Ref. American Venous Forum Guidelines. The sonographer must image the junctional areas, e.g. SFJ, closely. Option A is unsafe as proximal extension must be ruled out. B is unnecessary unless reflux is a concern. D is premature unless deep thrombosis is confirmed. Question 4. In contrast to arterial studies, venous evaluations often require dynamic positioning to detect reflux. Which of the following best describes the recommended positioning during lower extremity reflux assessment? A. Supine with legs elevated above heart level. B. Reverse Trendelenburg or standing for gravitational assistance. C. Lateral decubitus with flexed knees. D. Sitting upright with legs dangling. Answer. Correct answer. B. Explanation. Venous reflux evaluation relies on gravitational pressure, therefore patients should be in reverse Trendelenburg or standing. This promotes venous distension and allows physiological assessment of reflux with Valsalva or manual augmentation. Ref SVU positioning guidelines. A minimizes hydrostatic pressure masking reflux. C and D are not standard for reflux testing. Question 5. When analyzing a Doppler spectrum from the popliteal vein of Istachen, a phlebology sonographer observes a steady, non-phasic flow with diminished respiratory variation. The patient is not holding breath and there is no proximal compression. What is the likely interpretation? A. The waveform indicates normal venous function. B. Suggestive of distal obstruction like cath thrombosis. C. Consistent with proximal venous obstruction, possibly in iliac or femoral vein. D. A technical artifact due to poor gain settings. Answer. Correct answer. C. Explanation. Loss of respiratory phasicity with steady flow in large veins often indicates proximal obstruction. E.g., iliac vein thrombosis or compression. Normally veins show respiratory modulation. A is false due to absent phasicity. B would cause more localized changes. D may affect display, but phasicity is a physiological trait not altered by gain settings. Ref. Sweebel's vascular sonography, 5th ed. Question 6. The growing trend in point-of-care venous ultrasound increases the need for awareness of bioeffects. Which of the following is a correct guideline related to ALARA as low as reasonably achievable? Principle A. Increase Doppler output power to improve velocity accuracy. B. Use the highest mechanical index to ensure full penetration. C. Prolong scanning time if the image is suboptimal. D. Optimize settings while minimizing exposure duration and intensity. Answer. Correct answer. D. Explanation. The ALARA principle endorsed by the AM and FDA dictates that sonographers must balance image quality with safety by using the lowest output power and shortest duration necessary. A, B, and C all violate ALARA and may increase the risk of bioeffects like cavitation or heating, especially in spectral and color Doppler modes where power output is higher. Question 7. Based on the information Istihadad undergoes a venous ultrasound to evaluate suspect DVT, the sonographer notes that the femoral vein is non-compressible but shows partial flow with color Doppler and spectral Doppler reveals sluggish phasic flow. What is the most accurate conclusion? A. The vein is patent but underfilled due to volume depletion. B. The findings are consistent with acute DVT. C. Chronic post-thrombotic changes with partial obstruction. D. The vein is artifactually non-compressible due to probe angle. Answer. Correct answer. B. Explanation. QDVT often presents with non-compressibility, intraluminal thrombus, hypoechoic or anechoic, reduced phasic flow, and poor augmentation response. Color and spectral flow don't exclude thrombosis as partial flow can remain. Ref SVDVT protocols A and D do not match the pathology. C would show wall thickening and echogenic thrombus. Question 8. In a modern context of chronic venous disease management, what is the role of duplex ultrasound in guiding treatment decisions? A. It is only used to rule out DVT prior to procedures. B. It provides no value after sclerotherapy has been initiated. C. It helps evaluate reflux patterns, guide intervention, and assess post-treatment success. D. It has limited use in patients with SEEP class 1-3. Answer. Correct answer. C. Explanation. Duplex ultrasound is central to diagnosing reflux, mapping veins pre-procedurally, guiding interventions, and confirming treatment efficacy. It remains useful in all SEEP stages. It is not limited to DVT screening and continues to be essential post-sclerotherapy or ablation. Ref. American College of Phlebology Consensus Document. Question 9. Taking into account the risk of perforator vein reflux in patients with advanced venous disease, what is the clinical importance of evaluating these vessels? A. They connect superficial veins to lymphatics and assist in fluid regulation. B. Refluxing perforators may contribute to ulceration and should be documented. C. They have no hemodynamic significance if superficial veins are competent. D. They are best evaluated with MRI rather than ultrasound. Answer. Correct answer. B. Explanation. Perforating veins connect superficial and deep systems. When incompetent, they allow retrograde flow into superficial systems, increasing venous hypertension, often contributing to ulceration and CCI disease. Ultrasound is the standard for assessing reflux, 0.35 sec, especially with Valsalva or distal augmentation. A is incorrect. They connect venous, not lymphatic systems. C and D are both false. Question 10. The effectiveness of combining ultrasound and D-dimer testing lies in their diagnostic synergy. In a low-risk patient, well, score 1. What is the significance of negative D-dimer and normal venous ultrasound? A. DVT is ruled out and no further testing is needed. B. Thrombosis is still likely. Repeat scan in 24 hours. C. D-dimer is not relevant to venous ultrasound interpretation. D. Anticoagulation must still be started until definitive imaging. Answer. Correct answer A. Explanation. According to NICE guidelines, in patients with low pre-test probability and negative D-dimer, the negative predictive value is high and further imaging is unnecessary. B is false for low risk plus negative result. C underplays the complementary nature of lab and imaging. D would be unnecessary unless the clinical picture changes. Question 11. Given the circumstances that a patient presents with a history of unexplained swelling in the left lower extremity, with increased pain upon walking, what should be the most appropriate initial approach for assessing the deep venous system using duplex ultrasound? A. Perform a compression study of the femoral and popliteal veins, focusing on the compressibility of the veins. B. Begin by performing a Doppler waveform analysis to assess the velocity of blood flow. C. Use color Doppler to evaluate the superficial veins for reflux and varicosities. D. Evaluate the patient's calf muscle pump to detect any disruptions in venous return. Answer. Correct answer A. Perform a compression study of the femoral and popliteal veins, focusing on the compressibility of the veins. Explanation. In cases of suspected deep vein thrombus DVT, the most common initial approach involves performing a compression ultrasound study of the femoral and popliteal veins. This approach assesses the compressibility of the veins, which is indicative of thrombosis. The inability to compress the vein is a hallmark. DVT, Doppler waveform analysis, is more useful in assessing flow patterns but would not replace the need for initial compression testing. The calf muscle pump can be evaluated later in assessing venous return, but it is secondary to confirming the presence of EVE. Question 12. In what way can ultrasound assist in differentiating between primary and secondary varicose veins in the lower extremities? A. By assessing the number of superficial veins affected. B. By analyzing the flow direction and the presence of reflux in the saphenous veins. C. By using Doppler to evaluate blood pressure differences between deep and superficial veins. D. By examining the size of perforating veins and their relationship to the deep venous system. Answer. Correct answer. B. By analyzing the flow direction and the presence of reflux in the saphenous veins. Explanation. Ultrasound is particularly useful in identifying reflux, which is a key indicator of venous insufficiency and varicosities. When assessing varicose veins, the primary difference between primary and secondary varicosities lies in the presence and location of reflux in the saphenous veins and their tributaries. In primary varicose veins, is typically confined to the superficial venous system, while in secondary varicose veins, reflux may be associated with deeper venous pathology, such as deep vein thrombosis or post-thrombotic syndrome. These other options relate to general ultrasound techniques but are not specific for differentiating between primary and secondary varicosities. Question 13. What factors contribute to the formation of venous ulcers, and how can ultrasound findings assist in diagnosis and treatment planning? A. Increased pressure and reflux in the superficial veins, identified by evaluating perforating vein reflux. B. Insufficient deep venous flow and non-compressible veins, identified by Doppler velocity analysis. C. Prolonged compression in the calf muscle pump and visible varicosities. D. Obstruction of the iliac veins and subsequent stasis confirmed through Doppler waveform analysis of the common femoral vein. Answer. Correct answer A. Increased pressure and reflux in the superficial veins identified by evaluating perforating vein reflux. Explanation. Venous ulcers are often a result of venous insufficiency where increased pressure within the veins, particularly in the superficial venous system, leads to skin breakdown and ulceration. Reflux, especially in perforating veins, causes backward flow of blood into the superficial system, raising venous pressure. This can lead to damage and ulcer formation. Doppler studies that assess for reflux in the saphenous or perforating veins are critical in both diagnosing venous ulcers and guiding treatment decisions such as sclerotherapy, compression therapy, or surgery. Question 14. When performing a duplex ultrasound for deep vein thrombus (DVT), I notice what would an abnormal Doppler waveform look like in a non-compressible vein. A. Increased velocity with normal pulsatile flow. B. High velocity flow with reversed direction. C. Absence of flow with a flat line pattern. D. Continuous non-phasic flow. Answer. Correct answer D. Continuous non-phasic flow. Explanation. In DVT, the presence of an abnormal Doppler waveform in a non-compressible vein typically results in continuous non-phasic flow. This absence of phasicity, which should normally vary with respiration, is indicative of a thrombus obstructing the vein. This abnormal flow pattern is characteristic of a vein that is not compressible due to thrombosis. Reversed flow or increased velocity indicate other vascular conditions, but not necessarily DVT. Pulsatile flow is typically associated with arterial, not venous conditions. Question 15. Based on the information regarding May-Thurner syndrome, what ultrasound findings would be most indicative of this condition? A. Complete occlusion of the left iliac vein with no flow. B. Compression of the left common iliac vein by the overlying right common iliac artery. C. Dilated right common iliac vein with excessive flow. D. Presence of thrombus in the right femoral vein with absent compressibility. Answer. Correct answer. B. Compression of the left common iliac vein by the overlying right common iliac artery. Explanation. May-Thurner syndrome is characterized by the compression of the left common iliac vein by the overlying right common iliac artery, leading to increased risk of deep vein thrombosis in the left leg. This compression can cause venous stasis, leading to thrombus formation. Duplex ultrasound would show narrowing or compression of the left iliac vein, which can be confirmed through Doppler imaging. Other options like complete occlusion or thrombus in the femoral vein do not specifically correlate with May-Thurner syndrome. Question 16. What role does time gain compensation (TGC) play in optimizing venous ultrasound imaging, and how can proper settings affect the diagnostic outcome? A. It adjusts the depth of the ultrasound waves to enhance visualization of deep veins. B. It helps optimize gain settings for better visualization of superficial veins without amplifying background noise. C. It fine-tunes the focus to distinguish between arterial and venous flow. D. It compensates for attenuation by increasing gain at deeper tissue layers. Answer. Correct answer. D. It compensates for attenuation by increasing gain at deeper tissue layers. Explanation. Time gain compensation (TGC) is used to adjust the gain settings at various depths, compensating for attenuation that naturally occurs as ultrasound waves pass through tissue. This feature is crucial for improving the visualization of deep veins where signal strength is reduced. Incorrect TGC settings can lead to poor visualization of structures, potentially obscuring important findings such as thrombus or venous reflux. Proper TGC adjustment ensures that both superficial and deep structures are visualized clearly and accurately. Question 17. What is the most important consideration when preparing a patient for a venous ultrasound exam to ensure reliable and accurate results? A. Ensuring the patient is well hydrated to facilitate blood flow. B. Ensuring the patient remains still and refrains from moving during the exam. C. Positioning the patient in a reverse Trendelenburg position to enhance vein distension. D. Asking the patient to perform a Valsalva maneuver during the initial scan to provoke reflux. Answer. Correct answer. C. Positioning the patient in a reverse Trendelenburg position to enhance vein distension. Explanation. Positioning is critical in optimizing venous ultrasound results. For lower extremity venous exams, the reverse Trendelenburg position, where the legs are elevated slightly, helps enhance vein distension and facilitates the identification of reflux or other abnormalities. While hydration can be helpful for overall vascular health, does not specifically aid the ultrasound exam. Keeping the patient still is important for clear images, but proper positioning plays a more significant role in obtaining accurate results. The Valsalva maneuver is used later in the exam to assess for reflux, but is not part of initial positioning. Question 18. In light of recent developments in venous ultrasound technology, how do newer ultrasound systems improve the diagnosis of varicose veins? A. By providing higher frequency probes for better resolution of deep veins. B. By utilizing Doppler imaging exclusively for the evaluation of superficial veins. C. By using advanced 3D imaging to map the entire venous system. D. By allowing simultaneous color Doppler and spectral Doppler analysis for real-time reflux assessment. Answer. Correct answer. D. By allowing simultaneous color Doppler and spectral Doppler analysis for real-time reflux assessment. Explanation. Newer ultrasound systems have improved the accuracy and efficiency of diagnosing varicose veins through enhanced Doppler capabilities. Simultaneous color Doppler and spectral Doppler imaging allow clinicians to visualize blood flow and detect reflux in real time, which is essential for accurately diagnosing insufficiency. This combined approach offers a more comprehensive evaluation than traditional techniques where color and spectral Doppler were performed separately. High-frequency probes provide better resolution for superficial veins but do not directly improve the assessment of deep veins in varicose vein diagnosis. Question 19. Under the assumption that a patient presents with suspected chronic venous insufficiency (CVI), how would duplex ultrasound findings assist in confirming the diagnosis? A. The absence of visible varicosities, but presence of reflux in the deep veins. B. The detection of thrombosis in the femoral vein with non-compressible segments. C. The observation of reflux in the great saphenous vein and its tributaries during both standing and supine positions. D. The identification of superficial veins without reflux but with dilated venous segments. Answer. Correct answer. C. The observation of reflux in the great saphenous vein and its tributaries during both standing and supine positions. Explanation. Chronic venous insufficiency (CVI) is often diagnosed when there is reflux in the superficial venous system, such as in the great saphenous vein (DSV). Duplex ultrasound is ideal for detecting reflux by assessing blood flow in real time, especially when the patient is in both standing and supine positions. This allows for a dynamic assessment of venous insufficiency. Thrombosis and non-compressible veins are indicative of DVT, but not CVI, and dilated veins without reflux may indicate varicosities rather than CEI. Reflux is a critical finding for CVI diagnosis. Question 20. In terms of ultrasound artifacts, how can you distinguish between mirror imaging and true anatomic structures in a venous ultrasound exam? A mirror imaging appears as a duplicated structure that follows the same trajectory but is at a different depth. B. Mirror imaging results in a complete loss of venous flow, unlike true anatomic structures. C. Mirror imaging can only be corrected by adjusting the Doppler settings, not the gain. D. Mirror imaging will appear as a brighter, more intense image than the actual vessel structure. Answer. Correct answer. A mirror imaging appears as a duplicated structure that follows the same trajectory but is at a different depth. Explanation. Mirror imaging is an artifact that occurs when the ultrasound waves are reflected off a strong reflector such as a large vessel and appear as if they are coming from a different depth. This results in the appearance of duplicated structures, potentially leading to diagnostic errors. True anatomical structures do not exhibit duplication, and the artifact can be corrected by adjusting the gain, depth, or focus settings on the ultrasound machine. Other options do not accurately describe mirror imaging artifacts. Question 21. A patient with chronic venous insufficiency (CNI) presents with bilateral leg edema and varicosities. Which ultrasound finding would most likely confirm the presence of deep venous reflux contributing to the condition? A. Reversed flow in the popliteal vein. B. Normal phasic flow in the femoral vein. C. Increased velocity in the deep veins without reflux. D. Reflux in the great saphenous vein and its tributaries. Answer. Correct answer. A. Reversed flow in the popliteal vein. Explanation. Chronic venous insufficiency can be confirmed when there is reflux in the deep venous system, such as the popliteal vein. The reversed flow indicates impaired venous return and contributes to edema and varicosities. Normal phasic flow or increased velocity without reflux does not indicate CCI. Reflux in the great saphenous vein is typical of superficial venous insufficiency but may contribute to the overall venous condition. Question 22. A patient undergoing evaluation for a suspected deep vein thrombus (DVT) shows signs of swelling in the left calf and a non-compressible left femoral vein on ultrasound. What would be the next step in evaluating the patient's condition? A. Assess the contralateral femoral vein for signs of thrombosis. B. Perform complete lower extremity venous ultrasound including the popliteal and tibial veins. C. Perform color Doppler evaluation of the perineal veins. D. Begin anticoagulation therapy immediately without further imaging. Answer. Correct answer. B. Perform a complete lower extremity venous ultrasound including the popliteal and tibial veins. Explanation. A non-compressible femoral vein suggests thrombosis in the deep venous system. The next step is to perform a complete lower extremity venous ultrasound to assess other areas such as the popliteal and tibial veins for any additional thrombus. Assessing the contralateral femoral vein or focusing only on the perineal veins not fully rule out DVT in the affected leg. Anticoagulation should not be initiated until the full extent of the thrombosis is determined. Question 23. When performing a duplex ultrasound to assess for varicose veins, which of the following findings would indicate a need for further investigation of the deep venous system? A. The presence of reflux in the great saphenous vein. B. The presence of reflux in the small saphenous vein. C. Dilated, non-compressible veins in the calf. D. Reflux in the perforating veins. Answer. Correct answer. D. Reflux in the perforating veins. Explanation. Reflux in the perforating veins can indicate that the deep venous system is contributing to venous insufficiency, which warrants further investigation. While reflux in the great and small saphenous veins is common in varicose veins, the perforating veins are responsible for connecting the superficial and deep venous systems. If these veins are involved in reflux, it suggests that the deep system may also be compromised, requiring a more comprehensive evaluation. Question 24. During an ultrasound examination for suspected deep vein thrombus (DVT), you observe a non-compressible femoral vein with absent flow. What should you expect to see on the Doppler waveform for this segment of the vein? A. High velocity, pulsatile flow. B. Continuous, non-phasic flow. C. No detectable flow. D. Reversed flow with low velocity. Answer. Correct answer. B. Continuous, non-phasic flow. Explanation. In the presence of a thrombus, the flow in the affected vein is often continuous and non-phasic due to the obstruction of blood flow. This is a hallmark sign of DVT. High-velocity pulsatile flow is more characteristic of arterial rather than venous flow. Reversed flow is not typically seen in DVT unless the thrombus is severe enough to lead to retrograde flow, and no detectable flow is an unusual finding. Question 25. A patient has a history of recurrent superficial thrombophlebitis and now complains of leg swelling. Duplex ultrasound reveals a thrombus in the left great saphenous vein. What is the most appropriate next step in management? A. Begin compression stockings and conservative management. B. Perform a venogram to confirm the diagnosis. C. Prescribe anticoagulation therapy and monitor for signs of DVT. D. Schedule the patient for sclerotherapy to treat the superficial veins. Answer. Correct answer. C. Prescribe anticoagulation therapy and monitor for signs of DVT. Explanation. A thrombus in the great saphenous vein increases the risk of extending into the deep venous system, which could lead to DVT. Anticoagulation therapy is the appropriate treatment to reduce the risk of further thrombus formation and embolism. Compression stockings can help with symptom management, but they are not the mainstay of treatment in situation. Sonography is rarely needed, with duplex ultrasound being the gold standard for diagnosing thrombosis. Sclerotherapy is used for varicose veins, but is not appropriate for thrombotic conditions. Question 26. During an ultrasound evaluation of a patient with a history of DVT, what ultrasound finding would suggest the presence of post-thrombotic syndrome, A. Recanalization of the thrombus in the femoral vein, B. Normal phasic flow with no evidence of reflux, C. A large, non-compressible segment in the deep veins with no collateral flow, D. Presence of collateral veins in the calf with reversed flow in the femoral vein. Answer. Correct answer. D. Presence of collateral veins in the calf with reversed flow in the femoral vein. Explanation. Post-thrombotic syndrome (PTS), a common complication of DVT resulting from venous reflux and venous hypertension. The presence of collateral veins are often due to the inability of the deep veins to adequately drain the leg, and reversed flow in the femoral vein is indicative of PTS. Recanalization of a previous thrombus without presence of collateral flow does not indicate PTS. Normal flow without reflux is the sign of healthy veins. Question 27. What is the most common complication seen on ultrasound in patients with chronic venous insufficiency, CCI, and varicose veins? A. The formation of a thrombus in the saphenous vein. B. Increased venous pressure leading to skin ulceration. C. Reflux in the deep venous system. D. Venous compression due to external factors like tumors. Answer. Correct answer. B. Increased venous pressure leading to skin ulceration. Explanation. Chronic venous insufficiency often leads to elevated venous pressure in the legs, which can cause skin changes and eventually lead to venous ulcers. The most common ultrasound findings in these patients include reflux in the superficial veins, but the long-term complication of CVI is the development of skin ulcers due to poor venous return and elevated pressure. Thrombus in the saphenous vein is a possible complication, but less common in CCI alone. Question 20. In assessing a patient with suspected deep vein thrombus DVT using duplex ultrasound, which of the following findings would confirm the diagnosis of DVT? A. Flow reversal in the popliteal vein. B. A non-compressible vein with absent flow. C. Increased flow velocity in the femoral vein. D. Color Doppler showing turbulence in the tibial veins. Answer. Correct answer. B. A non-compressible vein with absent flow. Explanation. A non-compressible vein that shows absent flow is a strong indicator of deep vein thrombosis. Thrombus within the vein prevents its compression during the ultrasound exam, and the absence of flow confirms the obstruction. Flow reversal may occur in certain cases, but it is not sufficient alone to diagnose DVT. Increased velocity and turbulence are more typical about pathology. Question 29. When using duplex ultrasound to assess a patient for suspected superficial thrombophlebitis, which finding would support the diagnosis? A. A non-compressible dilated superficial vein with normal Doppler waveform. B. A compressible, well-defined superficial vein with reflux. C. A non-compressible dilated superficial vein with hypochoke material inside. D. Normal flow in the superficial veins with slight varicosities. Answer. Correct answer. C. A non-compressible dilated superficial vein with hypochoic material inside. Explanation. Superficial thrombophlebitis is confirmed when a superficial vein is non-compressible and contains thrombus, which often appears as hypochoic material on ultrasound. A reflux and dilated veins are associated with varicosities, but not thrombophlebitis. A compressible vein would not be indicative of thrombophlebitis. Normal flow and not support the diagnosis of thrombophlebitis in the presence of varicosities. Question 30. In a duplex ultrasound for varicose veins, which feature would be a key indicator of venous insufficiency in the great saphenous vein? A. A continuous Doppler waveform without phasic variation. B. The presence of normal phasic flow with peak systolic velocities. C. Reflux in the great saphenous vein lasting longer than 0.5 seconds. D. Decreased Doppler signal in the superficial veins with no reflux. Answer. Correct answer. C. Reflux in the great saphenous vein lasting longer than 0.5 seconds. Explanation. Reflux lasting more than 0.5 seconds in the great saphenous vein is a key indicator of venous insufficiency. This prolonged reflux indicates that the valve function in the vein is compromised, leading to venous hypertension and varicose veins. A continuous Doppler waveform without phasic variation suggests deep vein involvement, while normal phasic flow with peak systolic velocities is typical for healthy veins. Reduced Doppler signals with no reflux suggest the absence of venous insufficiency.